Hello, my name is Dr. Michelle Robbin, and I'm professor of radiology at the University of Alabama at Birmingham. I'm really excited to be able to give you this lecture today on elastography. It's not such a stretch. We've done about 100 of these exams a month since 2015, and it's a rapidly evolving area, one that you definitely need to be doing. This is my conflict of interest disclosure. So ultrasound elastography is a very complex topic, but I'm going to break it down into why we should be doing it, describe the types of elastography that there are out there, how to perform and interpret, and then we'll discuss artifacts and challenges, and then follow that by a summary. The reason why we need to do this is because chronic liver disease is a major worldwide problem. What we're looking for is fibrosis, and you can get fibrosis from chronic viral hepatitis, alcoholic liver disease, and non-alcoholic fatty liver disease, which is really a huge issue worldwide that can range from just mild steatosis to non-alcoholic steatohepatitis, and that can be so severe as to require liver transplantation, and the incidence of this disease is increasing. And then there are other reasons for fibrosis as well. The problem with fibrosis is that when you have fibrosis, it leads to cirrhosis, and that can end up with portal hypertension, variceal bleeding, and liver failure. There's also an increased risk of HCC in some cases with cirrhosis. So how is liver fibrosis staged? First of all, you have a normal smooth liver, and then you start ending up with periportal fibrosis, and this is on pathology. And then you end up with bridging fibrosis, and then finally nodularity. And I think of this stage as a sidewalk with lots of little rocks in it and the cement around the rocks. So for liver fibrosis, it's a continuum, as we just saw, and it's categorized by multiple grading systems. You'll have to figure out which one your institution uses. And the liver stiffness increases with higher fibrosis stages. So imagine that soft liver that you might get at the supermarket, and then imagine the stiffness of your sidewalk. Why should we grade liver fibrosis? Well, there are two categories of patients. One is asymptomatic, and that is those patients who have compensated advanced chronic liver disease. And in those patients, their median survival is about 12 years, and you may be able to avoid some screening exams. Those patients with decompensated cirrhosis, however, have a much higher risk of death and complications, and their median survival is only 2 years. So this distinction is critical in terms of managing patients. So the evaluation for liver fibrosis starts with patient history, physical examination, and labs, and ultrasound. And ultrasound is looking for the morphology and looking for the typical morphologic features of cirrhosis, and then also the sequela of cirrhosis. But we need an accurate quantitative measure of fibrosis, and we need accurate quantitative measure because we want to plan therapy, we want to assess for the response to that therapy, and then we also need to determine whether we need to screen those patients for malignancy or maybe we don't, and then also determine the potential to reverse disease. Well, in the old days, we would just go right to liver biopsy, but that's a very flawed gold standard because of sampling bias. Even if you take a couple simple samples, the liver is quite heterogeneous, so you may end up in an area with more or less fibrosis than the sum of the total liver fibrosis that's there, and the samples are small, and it's expensive as well as invasive with a risk of bleeding and pain. The first ultrasound elastography to be developed has been in place for quite some time now, and it is a non-imaging technique. It's called transient elastography. There are many, many articles in the literature about that, including meta-analyses, and it's a non-invasive technique using ultrasound. There's an external device that provides the shear wave that goes through the liver. Unfortunately, there's uncertainty since it's a non-imaging device regarding where that region of interest is placed. So if you have a large amount of ascites or if you're very obese, maybe the region of interest is in the fat or in the ascites. You don't know if it's in the liver, in a vessel, in a mass. You don't know where it is. Also, the spring that is needed in the external device needs to be recalibrated at 6 to 12 month intervals. So This is not the optimal, particularly for an imager. This is a perfect example of a patient in whom transient elastography may be wrong. There's a large amount of ascites, and you can see there's some subcutaneous tissue as well, and then there's a nodular cirrhotic liver, but this region of interest is perfectly positioned. So ultrasound elastography using imaging has been developed, and the technique is called acoustic radiation force impulse, also called ARFI for short. And what happens is the ultrasound scanner generates shear waves in the liver, and that displacement of liver is measured over time. So the shear waves are generated, and then we watch them go through the region of interest. And the shear waves, again, travel faster in stiffer liver. So that's how we determine what the difference of stiffness is. This is a nice example of a push pulse from a transducer, and then you can see the waves propagating out laterally. And this is what that looks like in a phantom. Here's the push pulse, a single push pulse, and then these waves go out laterally, and we can measure the speed of that motion. So there's two current types of shear wave speed measurement, and everyone implements this a little bit differently. There is one type called point shear wave, kind of like a point and shoot camera. You get what you get. And then there's another one that is 2D shear wave imaging. It gives you a larger measurement area, a larger region of interest, and you can perform multiple measurements in a single acquisition. And these have been changing fairly rapidly with different vendors. We're going to transition now to how to perform the elastography exam. The first thing you need to do when you're walking down the hall with the patient is to say, when is the last time you had anything to eat or drink? They need to be NPO at least 4 hours, because the food that they have eaten, particularly if it's high in fat or sugar, can increase the liver stiffness. So they can have their meds with water. 3 hours is okay, but a bare minimum. We generally try to have them come back if they've eaten a sausage and biscuit right before they've come in, because if you measure it and it's abnormal, then you've got to have them come back anyway. But that's an individual lab decision. Once you've got them on the table, the arm needs to be elevated over the head to stretch out their ribs, because we're going to be scanning the liver through the inner space of the ribs. They need to be in the supine position, but you can decube up to 30 to 45 degrees. And some people would say you could decube up to 90 if you can't get good imaging any other way. You should use very light pressure of the transducer probe on the skin, not too firm. You're going to be imaging parallel to the ribs, and that's an oblique method that most people don't use. We're used to using transverse or longitudinal views, not oblique. So sometimes we have to be reminded that we need to be parallel to the ribs. If you have a very narrow rib interspace, ask the patient to pretend that they're a banana and have them rotate their head and their feet. And sometimes that helps tremendously. Then we need to coach the patient on breath holding. The imaging needs to be obtained at mid-inspiration or mid-expiration. Sometimes people, when you tell them to hold their breath, they'll take a big deep breath in and then they'll Valsalva, and you don't want that. So sometimes the word pause is a little bit better, and in terms of having them hold their breath, if you ask them to pause their breathing, sometimes that works. But again, the only time we want them to stop breathing is in mid-inspiration or mid-expiration. Those are essentially equivalent. And then you need to wait a couple seconds for everything to stop jiggling before you actually take the measurement. So when you're in elastography, before you take a measurement, you need to look at the grayscale image. Can you see what you need to see? You may need to select a penetration preset once you're in the elastography mode, particularly if you have a very cirrhotic or steatotic liver, so that you can actually get enough shear waves to your sample volume. The optimal measurement location for elastography is about 4 to 5 centimeters from the skin surface, and that's because of signal to noise issues and also attenuation. So how do we do it? we're going to go over these and then I'm going to show you examples. You should be 1.5 to 2 centimeters from the liver capsule. And so we usually get everything all set up and then we actually measure to see where we're going to place our region of interest. You should be 1 to 2 centimeters from the rib shadow and vessels so that the transducer can create the shear waves, because you can't create a shear wave in Artifact. The transducer needs to be parallel to the liver edge, and it also, the region of interest needs to be parallel to the transducer and the liver edge. And we'll go over this in a minute. Also, the region of interest shouldn't be too far off center of the transducer. So this is an example. We sit down, we've got a nice look, and here is the transducer surface. The liver edge is parallel, and so is the region of interest. And we are about 2 centimeters from the surface of the liver, and we're at about 4.5 centimeters from the skin surface, which is optimal. So this is a very nicely positioned region of interest. This patient's region of interest is too close to the rib shadow. Here you can see rib shadow, probably another rib shadow. Again, the sonographer needs to be reminded to image in the oblique view. And here is the rib shadow that we need to fix. So once you go more in the oblique position in the intercostal space, you can see that now we have space on both sides. And so we're going to be able to get a much better region of interest. And this is one of the things that you particularly need to look for if you're having a wide variability in your measurements. This region of interest is not parallel to the liver surface. The liver surface is not parallel but oblique, but we've corrected it and we've moved this region of interest just a little bit out so that now the transducer and the liver edge and the region of interest are parallel. And all of these seem to be small points, but they're critical because you want to be as accurate as possible in your measurement and as reproducible as possible. This is a very cirrhotic patient and they can't hold their breath. You said pause breathing and yep, this is what you get. And sometimes that's just the way it is. You know that in those few patients, you're likely not going to be able to get a very accurate measurement because they're unable to hold their breath. This is a recent patient that we had, a 62-year-old male with a history of cirrhosis and no prior imaging. And you can see that, and so he's new to our system, don't have any history. They say he's got cirrhosis. Well, yes, he does. On the linear view, he's got a cirrhotic heterogeneous liver and quite a high kilopascals. His IQR over median is within our limits, but it's getting close. It's quite heterogeneous. So his high kilopascal reading is suggestive of clinically significant portal hypertension. The other thing we found was a 3.7 centimeter mass, and it is going to be very likely to be an HCC. So you need to be reminded to look very carefully in these patients for masses. And we see a mass probable HCC about at least once a week in our large patient population. Now let's talk about artifacts. This is a common artifact and a reason why we don't want to scan and place our region of interest too close to the liver surface. You can see there's an echogenic line on Glissen's capsule and you will have specular reflection here. In this image, you can see that high stiffness, and it's really because of the specular reflection, not because the liver is more stiff in this location. It's an artifact. And so that's why we don't scan within about 1.5 centimeters to 2 centimeters from the liver surface. Here we've positioned the region of interest more posteriorly, but you can see that we're unable to form a good shear wave in vessels. And so this is a confidence map. This is a 2D map that says, you know what, I really don't trust this. And as a matter of fact, the scanner says, you know, I don't trust it, so I'm not even going to show you anything in this blood vessel because I can't really measure a good blood vessel. So we don't want to have any region of interest or any measurement anywhere near a blood vessel or encompassing a blood vessel. That will give us less accuracy. This is a 2D map that shows the confidence of the measurement. And then this shows the elastography. When you're using a 2D map, don't take the stiffest, don't take the most soft, take the average. And if your manufacturer says that you can take multiple regions of interest, or measurements within this larger region of interest, go ahead and do so. So question, why do you only acquire the data in one area? Very important, and very important to make sure you can actually see it visually when you're examining your images. Make sure that the sonographer is trying to take the data in the same place. Well, first of all, we need to increase the precision of the measurement in one area so that we can get reproducibility data. When you're having trouble getting measurements that are similar, it's okay to delete bad measurements when something went wrong, the patient decided to breathe, or there's another technical issue. You also have to consider increasing your penetration if you're having trouble getting an adequate number. But a small percentage of these examinations will have low reliability, and some may have to go on to other techniques, such as MRI elastography, to be able to have some more success. So now let's move on to the report. The ultrasound scanner will calculate the shear wave speed in meters per second. There's a mathematical equation that converts that to kilopascals. So you can either report them both or report what your clinicians want to see. My clinicians want to see kilopascals, so I give them kilopascals. Now, don't actually ever try to measure or try to compare the elastography kilopascals that you get on an ultrasound scanner versus an MRI. There's a variety of reasons for that, but they both use different tables. So don't expect that these numbers are going to be the same. We need to report the median, not the mean, and then the interquartile range over the median. And that's a statistical measurement of variability. And when the median measurement is abnormal and the IQR over median is greater than 30%, the measurement accuracy is reduced, and you need to say that. You also need to describe for the next exam, when you're going to compare, what the patient position was, how long they've been NPO, and what ultrasound scanner that you used. All right, here's another question for you. What do you do if you have different ultrasound scanner manufacturers that perform elastography? Just do them all on one with one sonographer? Well, there's something called the Quantitative Imaging Biomarkers Alliance Initiative, and that's called KIAA through the Radiologic Society of North America. And the ultrasound shear wave speed group has done a fantastic job. It is a combination of vendors and scientists, people from the US FDA, and clinicians. And they have been very successful in developing standardized phantoms that the vendors use to standardize their measurements. So now, instead of having a vendor-specific table that we have to use, we're able to use, because the variability of manufacturers is decreased, we're able to use one single table. And Rich Barr, in sharing the SRU liver elastography consensus statement in 2020, and colleagues came up with an update that enabled a manufacturer independent cutoff table to grade elastography. And so there's basically three different categories. One is a low cutoff value, and that pretty much eliminates the need for follow-up, and that is those people who have no or mild fibrosis. Then there's a high cutoff value, those people that have a high probability of compensated advanced chronic liver disease, and they require definitely a different management and therapy prioritization. And then there's a big range in between the mild to moderate category, and that encompasses a large range of stiffness that also encompasses vendor differences. So we're actually doing a great job in terms of being able to now do some elastography on different equipment. Let's see some clinical examples. This is a 68-year-old woman with hepatitis C. She had a pretty decent stiffness. This is in kilopascals. And then she was treated with Harvoni. And after Harvoni treatment, her stiffness was 2.9. And that was a substantial difference that was within normal limits. And our GI recommendation said, look, you can return to the general population and we don't need to see you anymore. There's no further follow-up required. So huge importance in being able to actually monitor evaluation and response to treatment. This is a recent patient I had, a 68-year-old male with autoimmune hepatitis, and now he's got decompensated cirrhosis. He hasn't been taking his medicine because of the pandemic. And a year and a half ago, his elastography was pretty good. Now his liver looks terrible, it looks cirrhotic, and his kilopascal's number is quite high, which is corresponding with the morphology of his liver. So also you can order elastography alone, or you can order it with an abdominal ultrasound. If whichever choice you have, always look at least where you're measuring to see if there's masses. But if you're doing a whole limited abdominal ultrasound, look at that whole liver very carefully for HCC, because again, as I said before, liver mass detection is quite common. And this is a 60-year-old woman with hepatitis B that we were doing our first elastography on, and we had an incidental note of big masses. They turned out to be metastatic high-grade sarcoma, which was a surprise to everyone. Now we're going to spend just a couple minutes on training. Why do you need to train? You absolutely need to train so everybody's doing it the same way. So you have reliable, repeatable measurements. You want your gastroenterologists and other clinicians to actually absolutely trust your measurements regardless of where in your institution they're performed, at an outside clinic or at a hospital. We have 6 sites and more than 50 sonographers, so you can tell this is quite an undertaking, but it works very well once you have a methodical approach to it. We also need the radiologist to understand how to do this, because if you have a less experienced sonographer or a difficult patient, the radiologist needs to weigh in and say, look, try this so that we can hopefully salvage this examination. So at UAB, in training, the sonographers perform elastography on at least 10 people to learn the technique, and that's 10 measurements per patient. And at the time of the study, there's a back scanner or someone else that goes in and to instruct them as to how to do it correctly. And they also are the gold standard. And then, only then, do we begin our sign-off process, and they need 5 exams with a sonographer also scanning as a gold standard. And I look at them, and when they pass the 5 cases, then they're allowed to do elastography independently. And everybody wants to be able to do it independently. So there's significant pressure to get this done. But there is a checkoff process, and we compare them. The ultrasound images and the results are compared between the 2 examiners. The exams must be nearly perfect, because you don't want to have somebody say, oh yeah, I forgot that, and then do that same thing in a patient when they're scanning on their own. The sonographer shouldn't submit their hardest cases. Submit a good case that is well imaged, because it's very difficult to evaluate whether the images are poor because of patient and technical factors, or if the technique is poor. And hopefully this process will decrease inter and intra observer variability. And in general, our IQR over median is quite low. So in summary, the investigation to determine the degree of fibrosis in an individual patient starts with the clinical history, labs, and ultrasound. And then ultrasound imaging and elastography is the next best step. Remember to look for liver masses, including most often HCC, but sometimes metastases. And then elastography can help the clinician assess the need for further evaluation and treatment and further surveillance after treatment. I'm very proud to say that we have nearly eliminated non-targeted liver biopsy at UAB, which is a substantial practice change for us. I'd like to thank you for your attention.